Good morning, good afternoon, good evening to everybody. My name is Sophie Fay, and I work for the APT Associates Division of International Development. I also am the core portfolio manager for the USAID-funded Local Health System Sustainability Project, LHSS. Welcome, bienvenue to this APT Associate session on health financing and self-reliance, country experience on engaging all forces for a sustainable approach. Our session today is going to be rooted in the fact that preventable disease, both infectious and non-communicable, complication of pregnancy and childbirth, global health security risk, like extreme weather-related disaster and emerging global epidemics still claim too many lives and challenge the ability of countries' health system to cope. But in the same time, international aid is shrinking and country health budgets are mostly remaining flat. In the described context, it is particularly important for LMICs to build their self-reliance and be able to locally raise resources for health and use those resources efficiently, especially during health crises. And such goal is at the center of USAID journey to self-reliance with its partner countries. Our session today will feature a series of presentations designed to showcase country experience on how domestic financing to health is being mobilized across different sectors in normal time for routine health provision, but also for dealing with sudden health crises like the current COVID-19 pandemic. The presentation will be followed by a facilitated discussion to exchange on best practices that will be useful as countries and their partners work together toward the goal of self-reliance. Today, we'll have the pleasure to hear from several speakers, and I'm just gonna present all of them at the same time, but you will hear from them one after the other. We have first Dr. Eric Kitali, we have Eric Kitali, Director of Information, Communication and Technology at the President Office, Regional Administration on Local Government in Tanzania. Mr. Eric oversees the ICT infrastructure and network in Tanzania, which connects 185 local government authorities and 26 regions to a central location. Mr. Kitali is a computer scientist with extensive experience in local government systems. He has spent the past 8 years as the government focal point for ICT and manages many information systems at the national, regional, and local levels. We'll also hear from Dr. Tuli Kapologwe. He's Director of Health, Social Welfare, and Nutrition Services at the President Office, Regional Administration, and Local Government, still in Tanzania. Dr. Tuli is a medical doctor and public health professional with leadership experience in many institutions and associations at both national and international level. His PhD work focused on the effect of direct health facility financing initiative on the health system performance in Tanzania, and Dr. Tuli has been at this position of Director of Health Services since 2017. We'll also hear from Mbogo Buhi, Senior Private Sector Advisor at the Shops Plus project. It's a USAID-funded APT Associate-led project. And Mbogo is a Senior Private Sector Private Sector Advisor based in Kenya. He's gonna share about experience in Kenya, but he's a development professional with 19 years of experience in sub-Saharan Africa for the healthcare sector. He supports organization and government craft solution for their immediate challenges through private sector engagement. We are also going to hear from Dr. Yusuf Ndiaye, Director of Planning, Research and Statistics at Senegal Ministry of Health. Dr. Ndiaye is an MD, PhD, and currently Director of Planning in that ministry. He's a public health expert with 20 years of experience at different levels of the Senegalese health system, from district to region and central level. He's also coordinating the National Health financing strategy toward universal health coverage in Senegal. We'll then hear some remarks from Joe Cudson. Joe is head of the unit of the health financing unit at the WHO organization. Joe is lead health financing expert, and he is an economist with 35 years of experience working in Africa, Asia, and the Caribbean. Since joining WHO in 1994, he has served as WHO policy advisor to the Minister of Health of Kyrgyzstan, and also as the European region lead advisor on health financing. He has been a contributor to the World Health Report 2010 on financing for universal health coverage, and has published numerous conceptual and empirical articles about health financing and health systems. We will have the pleasure to hear from Ms. Kelly Saldana, Director of Office and Health System at USAID. Kelly will be moderating the panel discussion. Kelly Saldana is the Director of the Office of Health System for USAID Bureau of Global Health. She has more than 20 years of experience in public health administration and international development, having served in a variety of roles within USAID, including most recently Deputy Director for the Office of Infectious Disease, and previously with the Bureau of Latin America and the Caribbean. Kelly has been instrumental in the Acting on the Call report that's published annually in the past 6 years to demonstrate the work that USAID is doing and its partner to end preventable child and maternal death. So after this brief introduction of our panelists, I'm just gonna hand it over to Dr. Tuli and Eric. They will share about the Tanzania experience with direct facility financing. Over to you, Dr. Tuli.
Hi, everyone. I, with Eric, I shall be taking you through the topic on using direct facility financing and public financial management system to improve facility management of services delivered in Tanzania. Next slide, please. The direct facility financing as a reform emanated from the meeting of 2016, whereby different stakeholders echoed the concern of poor quality of services rendered by public primary health facilities. As a result, they came up with a resolution that there should be a financing mechanism whereby funds will go direct to the primary health facilities instead of going through the district head office. And some of the problems which were identified prior to the introduction of direct facility financing were insufficient financial and human resources at the point of service delivery, that is primary public health facilities. Then there were fragmentation and ineffectual public financial management system. Prior to the direct health facility financing, there were a number of systems which were fragmented and not speaking to each other. And the other problem was inadequate facility autonomy and accountability, particularly by the community governance and accountability structures, that is the Health Facility Governing Committee and Council Health Service Board. And some of the proposed solutions were now to come up with the direct facility financing as a shift from input-based financing to output-based payment, tying it to the results. And the other solutions were extension of cross-sectoral public financial management system to the facility level across the national, regional, and local government levels, including the public primary health facilities. And the other proposed solution was the government and development partner to work together through the Health Basket Fund and other sources of funds, like Community Health Fund, to ensure that the DHFF is implemented as per design. Next slide, please. So there were some preconditions prior to the introduction of direct facility financing, that the facility was supposed to have the bank accounts which is approved by the Bank of Tanzania, and through the Ministry of Finance, which was responsible for disbursement of fund direct to the facility, to have charts of account, which is with the official recognition of public provider autonomy. The other thing was realignment of institutional roles and relationship between the government of Tanzania and the non-state actors. And also the other thing was the presence of governance structures. As I said earlier on, the health facility governing committees and council health service board. The other thing was the primary facility, the public financial management system at the facility level to manage money through guidelines and also standard operating procedures. The other precondition was health facility annual plan and service performance data. Prior to the introduction of DHFF, there were no any guideline or there were no any plans or a budget which was developed by public primary health facilities. Instead, the district, they were the ones who prepared the budget and plans, and they were the ones who were determining how much should be actually dispersed to the public primary health facilities. The other one was output-based payment system. Next slide, please. Now, looking into the DHFF provider payment system, the DHFF was found to be the core for primary healthcare per capita payment to all dispensaries. In Tanzania, we have more than 5,000 public dispensaries, and also we have more than 700 health centers. And these do receive funds from the Health Basket Fund, and also they do receive funds from the local initiatives like community health financing. And these funds are distributed based on the base tranche and also performance tranche. And on the base tranche, the funds disbursement is determined by using three payment adjusters, namely the need, whereby we consider the issue of catchment population of these facilities, and then the performance, that is health service utilization, and the third one is on equity, which is actually calculated based on the distance from the district headquarters. But other sources of fund, as I said earlier on, is community health fund and the National Health Insurance Fund. And these are harmonized through the DHFF. Initially, they had resource allocation formula, which was not the same, but through DHFF, it has helped to harmonize these different sources of fund. But the local government authority as well, they have different sources of fund, which we call the district own sources. And these also, they are using the similar formula as are used for community health fund and national insurance fund. But also this builds on the foundation that in Tanzania, in the meantime, is embarking into having the universal health insurance. So having these different sources of fund will be part of the input in realizing that goal. But this also increases the facility preparation and the resilience towards the COVID-19 epidemic, because it has minimized the contact among healthcare providers and keeping them safe from contacting COVID-19 epidemic. Next slide, please. Now, looking into the DHFF provider payment system, then this also aligns to the payment to priority services, as these public primary health facilities, they tend to present with priorities, which are 13, and also these priorities mainly focuses on the distance, as I said, on the poverty index of particular handicapped land covered in that particular district answer. But still, has increased efficiency, and also this has helped to reduce waste, that buy the right thing at the right time. As we are progressing to implement DHFF, we also conducted the health system research where to look into how there is governance and accountability of finances at a public primary facility. And it turned out that some of the findings which we were able to get from that study was the health facility in charges were able to appreciate that following introduction of direct facility financing, there were improvement of quality of services rendered by public primary health facilities. And 76 of health facilities and the schools staff are not positive changes in working condition, as they could receive some incentive through direct facility financing, which they didn't experience prior to its introduction. The other thing is through the facility governing committee members, they were really able to appreciate that before our recent initiative, that is introduction of DHFF, it was difficult to call committee members to a meeting because there were no incentive whatsoever to be able actually to bring them or to convene a meeting. Next slide, please. So this is just to show you the DHFF management framework, whereby it shows the government roles and the relationship to other implementing and development partners. It has 8 components. The first one is disbursement of and receipt of funds through the bank account at a public primary health facility. The second one is to ensure all the public primary health facilities do have the planning and budgeting exercise prior to the disbursements fund, and all the procurement of health commodities now are done at public primary health facilities. And there's institution of internal controls. And the fifth one is there's accounting and reporting system through financial facility accounting and reporting system. And also as clinical service delivery, there is now improvement in the clinical health services delivered at the public primary facilities. And there's a human resources for health management. And the last is there's monitoring and evaluation, which is cutting across in the human resources for health and also in the public financial management system. So on that remark, let me take this opportunity to invite over my colleague, Mr. Eric Tari, to proceed with the next part of our presentation. Thank you.
Thank you, Dr. Antuli. Hi, everyone. I'll take you through the second part of our presentation. Next slide, please. As Dr. Ansul said, actually, the summary of what Dr. Ansul said is resources follows function. Where the activities are done is where we are disbursing the resources. In Tanzania, we do have the D/D policy, decentralization by devolution, where all the resources are going where the functions are taking place. And having the DHFF in Tanzania, actually we came up with tools whereby the facilities, as Dr. Ansul said, we have more than 5,000 facilities in Tanzania, dispensaries, hospitals, actually even the education sector, we do have other facilities. We came up with a system where we have to control all the resources which are going to the facilities. And now, before we disburse the resources, we need to do the planning. And doing the planning, we realize it is really difficult to do it in traditional way. So we have to come up with a system which can cover all the facilities, health and education, which is around 26,000 facilities. And back then, before 2017 and before DHFF, we do have the kind of a traditional old modern system, and we revamp it to a modern system, a centralized system, whereby all the planning, all the budgeting can be done from the facilities to the central level. And the way we did this, we make sure that as the DHFF stipulated, we make sure the resources which are going to be disbursed can be monitored. And this is more or less of a service output oriented planning, whereby we want to see the services at the end of the day, not really the input and output. And after coming up with this system, which we rolled out to the whole country, we do some research and we realize 53% reduction in cost, traveling and printing, and more than 60% reduction in staff time. That is the planning system. Next slide, please. Having the planning system, we have the expenditure system. This expenditure system is facility financial accounting and reporting system. Actually, all the facilities, after doing the planning and budgeting, we do export the plans to the expenditure system, which is FAST, so for them to do the expenditures. And after 1 year of using this system, actually this system also deployed and installed in facilities in 2017. After a year of using it, we do a simple research, and we realized 61% of the facility managers, they said the reporting became very simple, accurate, transparent, consistent, and they are using less paper comparing to the old system which we are using. Also, they are even saying it enhances service delivery and making the facility more aware of whatever they planned, whatever they budgeted, and whatever they are using right now. And having these two systems, the planning system, PlanRep, and the expenditure system FAST, it's easier for us across the board, from the facility to the local government authorities, to the regional level, to the central level. It's easier for us to see all the reports, consolidated reports of everything. It's easier for us to see the financial reporting and physical implementation report. Next slide, please. Now, the planning system and fasting system, they have to talk to each other. Next slide, please. Yes, this is the Muungano Gateway, our mediator, whereby it is integrating two systems. And in Tanzania, the way we are building systems, we make sure we even follow the WHO health system building blocks, whereby we ensure everything regarding the health sector is taken care of. And our Muungano Gateway is built based on the Open HIM, Open HIM, and it's the integrated systems within our ministry and outside our ministry. So it's easier for us to transfer data from one system to the other system. That is a brief. Next slide, please. That's the brief of DHFF in Tanzania, where we have money, we have systems, we have financials, all of them going to the facilities to ensure the services are delivered according to the health output which we are anticipated. Thank you very much. That's the end of our presentation, and we are ready for any response and question. Thank you. Over to you, Sophie.
Yes, thank you so much, Eric and Dr. Tuli. This is truly remarkable policy and reforms that Tanzania have been able to deploy, and in a very short time period. And I think we really want to emphasize the multisectoral aspect of this. As you mentioned, this reform is deployed to more than 26,000 schools and health facilities. So next we'll hear from Mbogo. And Mbogo will share about an experience in Kenya for public-private partnership. Over to you, Mbogo.
Thank you, Sophie, and thank you, Eric and Dr. Ntuli, for the leading presentation. Good evening, good afternoon, and good morning from wherever you are joining us today. My name is Mbogo Bunyi, and I am a senior private sector advisor on the USAID Shops Plus project, which is hosted at Apt Associates. And today I'm going to be sharing our lessons and experiences from work on the private sector side of domestic resource mobilization, highlighting lessons and experiences from a women's health project that we are working on in Kenya. Next slide, please. So we acknowledge that traditionally, DRM, or domestic resource mobilization, has focused on government and has looked at the government as the primary stakeholder in terms of either raising the resources or managing the resources. And recently, stakeholders in health have been looking more and more to the private sector and how can the private sector increase its contribution to DRM. In as much as there has been that effort and that focus on trying to bring out more from the private sector, there is not much consensus in terms of what does this really look like for private sector DRM, and in terms of both process and to what extent can private sector contribute to DRM. And as Shops Plus project, we have made efforts to inform this ongoing dialogue on how to bring in private sector DRM. And specifically, we have a brief that Shops Plus has published, and that what you see on the slide now is the title of the brief, Understanding Private Sector Domestic Resource Mobilization for Health. This is available on the Shops Plus website. And in it, we suggest both definitions, and we highlight examples of private sector domestic resource mobilization in an effort to inform these ongoing discussions for DRM in countries and self-resilience in countries. Now, for my discussion today, I have defined and I'm working with the definition of private sector DRM to include any mechanism or process that raises new funds for health by mobilizing resources from the local private sector. Next slide, please. Thank you. So for the activity background in Kenya, this began with a partnership was initiated in a partnership by two key partners. One is a corporate partner known as Twinings Tea. Twinings Tea is a global tea brand and is based in the UK. And they run an ethical tea sourcing program called Sourced with Care, which aims to improve the quality of life in the communities from which they source their tea. And the second partner is the USAID Shops Plus project, for which I work. And our project is USAID's flagship initiative in private sector health. So as a project, we seek to unleash the full potential of the private sector through public-private engagements to address public health priority areas. And typically, this is in the areas of family planning, HIV and AIDS, and maternal and child health. So as two partners, the partnership evolved and actually began around discussions began around 2017, 2018, where Twinings had been making investments through a program known as Her Health. Her Health is a program that seeks to disseminate or share health information to women in Twinings supply chain. So they have been investing in this since 2015. And around 2017, they made a commitment to expand this activity to reach more women. And as Shops Plus, as a project, of course, was looking for how do you effectively expand the impact of private sector to public health objectives. And that was how we came together and started having the discussion and aligned our mutual interests. And we defined the objective you see on the slide. And so the objective of this pilot and this work is to develop one global strategy that will enable Twinings to sustainably expand access to women's and child health products and services for all women in their supply chain. So this goes beyond just employees, but also smallholder farmers who I will speak to in a moment. And that this strategy will be informed by an initial pilot in Kenya. So that is the objective of the work we are doing together. And next slide, please. So thank you. So I mentioned smallholder farmers, and here we see a picture of one woman smallholder farmer in Kenya. And just to be on the same page of understanding, the tea industry supply chain has different sources of their tea. So there are typically tea producers, and these are larger companies who grow tea on acres and acres, hundreds or even thousands of acres of land, and then produce that tea. And they're supplied then now to other tea brands like Twinings. However, in addition to the supply from their large farms, there are they also source tea from smallholder farmers. So these are typically farmers who own a smaller acreage of less than 10 acres, and they will then supply the tea to these tea producers. So smallholder farmers, you can think of them as independently contracted farmers who plant tea on their own farms. And in Kenya, they fuel the agriculture industry. We find that up to 76% of women are employed in agriculture in Kenya, and up to 60% of Kenya's tea crop is produced by smallholder farmers. Now, this production is done despite significant health challenges facing women in Kenya, and these are some sample statistics. We are looking at about 362 maternal deaths per 100 live births, and we know that this is against a target of slightly over 100. We should be at about 100 as per SDG targets, deaths per 100,000 live births. And we also note that only a quarter of the poorest women are using a modern method of contraception. So that is the context within which we're working. Next slide, please. Thank you. So to design this pilot and this work, we had to connect and understand and speak to the smallholders, and they informed the design of the work we did. And how did we connect and get the information? We we did desktop research, looking at some of the information that already existed. And we also conducted site visits and spoke with different stakeholders and smallholders. And this slide highlights what we learned and what the smallholders informed us. So what were the challenges and opportunities? So first, products and services that women seek are often not available at the nearest health facility. Second, because those services are not available close by, it takes significant time and financial costs for the women to travel to the next health facility. Third, payment. Payment for the T income typically comes on monthly cycles, whereas we all know that health needs don't abide by monthly cycles. So at times, when women or their children have got a healthcare need, they don't have access to the cash when they need it. So those were challenges that were highlighted. Of course, we learned much more, but I'm just highlighting, say, the top three. Opportunity-wise, women in these areas belong to women's groups, and these women's groups in Kenya are called chama. And chamas serve both a social function as well as a financial function to improve the well-being of their members. Secondly, there was a conveniently located public health facility with some structures that existed close to these women. So based on this information, we designed a pilot and determined that we are going to refurbish an existing health facility. And alongside that, we're going to strengthen a women's group so that we can introduce small enterprises. And from those small enterprises, a portion of profits can go to support the supplies and maintenance of the nearby health facility. So that's the pilot design that we are working with. Next slide, please. So from the initial partnership and from the pilot design, then of course we needed to be able to make this come to fruition. And this required strong and committed domestic partners who are around and are working with the women in these areas. And this slide highlights who those partners are. And I'll speak to them starting with the first, which is SIRET OEP. SIRET OEP is a cooperative member organization, and it is made up of smallholder farmers. So this was formed and set up by smallholder farmers to further their interests over time. And so they have members who they support either through improving tea production or improving other areas of their life, for example, healthcare, which is a major need, as we saw earlier. The second partner who we highlight here is the public sector, and this is Nandi County. So in Kenya, we have at the national unit is the country, and the sub-national units are called counties. And so this activity was happening specifically within Nandi County. And so, of course, the Nandi County government is the custodian of health in the area and are responsible for running health facilities and providing services to the citizens there. The next partner that we got on this is EPK, and EPK is a tea producer. EPK stands for Eastern Produce Kenya. And so they are the tea producer who are in the area, and they work with a long-term emphasis on building agriculture enterprise, and as well as being committed to ethical business trading values. The last key partner who helped make this come to fruition is the women's group, and their name is Chepkiwen Women's Group. They came together and they seek to empower and improve the livelihood of their members, and they did have some income generating activities and other social activities. Next slide, please. So what refurbishments happened? So this slide shows us the infrastructure improvements before and after. What we have on the left was a partially completed structure that existed within the health facility compound, and this was initially constructed to be a residential house for staff. And this construction was done by SIRET OEP, who I highlighted earlier. Based on the feedback and with consultation with the partners, we agreed to refurbish this and improve it so that then this can now be an expanded health facility with a consultation room, pharmacy, laboratory, delivery room, plus more. Next slide, please. So those are the infrastructure improvements that happened. And then there were service improvements. So by way of this partnership and this refurbishment, these are services that are now available that previously were not. And this includes long-acting family planning services, delivery services, lab and diagnostic services. Aside from the services highlighted on this slide, there are also some health system interventions that the project worked on, and we are looking at electronic medical records and an increase in the health workers. And with this, we are looking at the facility being able to operate for 24 hours. Next slide, please. So there are a variety of domestic resources mobilized, and these are highlighted on the slide. The community land that was contributed to this, the partial construction of the health facility, like we saw. There was labor that partners put in, professional services to be able to get the work done. HRH and human resources for health were provided, commodities. And for going forward, resources from the income generation activities will go both to the women for their needs, as well as a portion of those will go to the health facility to improve both supplies and maintenance at the health facility. And I should mention at this point, part of the membership of Chepkiwen Women's Group also sits on the health management committee of this particular health facility, so that there's that ownership and that insight to support for needs that are responsive to what they want. Next slide, please. So what have we learned? We see that catalytic investments, often from donors in private sector DRM, they can contribute to countries' self-reliance. So both providing the technical assistance can help sharpen or improve the effectiveness of corporate social investments or corporate social responsibility initiatives. And also we find that investments once put in can leverage and attract contributions, both from individuals and from other foundations. I do want to say this, that there is, and highlight that there is the value that donors can often bring, not only through technical assistance, but also risk mitigation. The fact that a donor is associated with some DRM initiative helps in one, making the initiative be potentially stronger, and as well helps to reduce the risk for other private sector investors to put their money or their contributions towards the initiative. Second is that partnerships take time. They take time to build trust for each champion within each organization to be able to navigate their own organizational processes. I mean, like you've seen the number of partners, it takes time to understand the key people, the key decision makers, understand the decision-making cycles, and respect that relationships are king. They help provide the credibility to engage, and it takes time to build. Lastly, effective DRM requires multiple partners and multiple partners with aligned initiatives. It is likely that no single private sector entity can be able to contribute all the required resources for a specific health or development need. So you've got to bring them together, and you've got to then help each align and see how making these investments benefits both them and the communities within which they work, and contributes to long-term sustainability, both for the private sector, for the communities, and for the country. Thank you very much. Next slide, please. I believe that was my last slide. Thank you. Over to you, Sophie.
Yeah. Thanks, Mbogo. Thanks for this very interesting example of Kenya increasing access to care through a PPP model. I think we hear often about the role played by the private sector, but this is an example where not only private sector, but also the communities participated to providing their own health. And it's really, as we know, the most sustainable way of building these strong local health systems. So we'll now hear from Dr. Youssoufa Ndiaye. Dr. Youssoufa is from the Senegal MOH and will talk to us about how the country mobilized domestic resources for an effective response to COVID-19. Over to you, Dr. Youssoufa.
Thank you, Sophie, my pleasure. So the organizer, those online, it's my pleasure to share with you about how Senegal mobilized domestic resources for an effective response of COVID-19. Slide, s'il vous plaît, please. Sorry. Sorry for the French English sometimes, don't worry. So as we all know, WHO declared COVID-19 as a public health emergency on January 30. And 2 months after Senegal reported its first case of COVID-19. And the government decided 20 days after a state of emergency. It was not about only closure of schools and ban of large gathering. It was about a lot of measures that was able to shorten the contact within people. Slides, please. Before all, I would share with you quickly the Senegalese health system, what it looks like. It looks like what is happening in many countries in West Africa and all around Africa as well. We have two parts. One is in the administrative organization and the care service organization. In terms of, it is pyramidal in a way. And at the top, we have in the administration, the ministry office and general secretary, as you know. And the intermediate level, we have 14 medical regions managed by, medical officer with public health background and a great team, and 14 regional social action services and hygiene services. At the peripheral level, we have what we call health district, in which we're gonna have later, I'm gonna show, the health center, health post, and the community. We have the departmental, services of social action and hygiene. But this is appended to care services organization. We have 11 level 3 hospitals in Senegal at the national level. They are university hospital. And 10 of them, unfortunately, are based in Dakar. And 14 level hospital too, they are called regional hospital. And at the peripheral level now, which is the reality of the work I can tell. So we have 10 level 1 hospital. In this hospital, we can make C-section, we have sometimes pediatrician, and we have 103 health centers with medical officer and a team of medical and all staff. We have nearly 1,400 health posts and 2,700 health at the community level. Slide, please. So it happens, as you know, COVID-19 happens, but before it happens, when international alert was done, Senegal developed a response preparedness plan that include assessment of the country capacities to cope with COVID-19. At that time, it was only in China. We didn't know when, where, but we were really sure that it's probably going to happen in the country. And to do this assessment, nine components were studied, like laboratory capacity, risk communication and community engagement, coordination, rapid response team, case management, logistic, entry points, what is very important, you're going to see later, the infection prevention and control, and the surveillance. These are the basis of our criteria to identify 45 health districts. And you can see on the map that most of the districts, they are at the borders of countries like Mauritania, Gambia, Guinea, and Guinea-Bissau. We have 2 special districts, if I can tell so, in Touba, which is a religious center where millions of people are gathering every year. And we have Kaulak, which is at the center of the country, and all the roads are going through. So apart from that, they are in borders. Dakar as well is a border because Dakar, you have the international airport. Slide, please. So we have the preparatory phase. Unfortunately, we got this first case and we were in the response. We didn't wait the response to come, and we developed multisectoral approach for a response, adaptive response. This was done through the contingency plan, but this was done through, 2 main components, main support. One is the National Committee for Epidemics Management, what we call CNG in French. This didn't appear with only the COVID-19. This was done before or just after, if I mind, Ebola pandemic. So we learned from that. And its role was to monitor and follow up the trend of disease, oversee preparedness, prevention, and response, as well organize evaluation of the response to epidemics. The first evaluation was made 6 months after what we call RIA, And this is more strategic, as you can know. And we have at this place all the line ministries, the community, civil society, and so on. It's a big shot. We have an operational arm of that. It's what we call Senegal Health Emergency Operations Center. This center was born after COVID-19, Ebola crisis. And it is really the operational, component of this. And its role is to define emergency measure, to coordinate actors involved in the response, to supervise the field operation, and to liaise between emergency response actors and Ministry of Health. So, which is a very important role. They are as well doing many other things like simulation, like developing plans, and so on. Slide, please. I would say, at this time, Senegal did have, slightly good results in the fight against COVID-19. How to do it? Which resources was used to have these results? What's going on? We're gonna talk about domestic financing mechanism and non-domestic, external financing mechanism. But I would say first, Senegal did quickly many action in terms of mobilizing domestic resources. One was like respecting, the normal way of using national funds by the initial finance law, as you know, which is the most current way. The budget line, rapid response to epidemics, is one line. Unfortunately, this line was not very important in terms of resources. Another way is amending financing law, what was done in Senegal. Credit reserve advance decrease. We did advance decrease in Senegal, and we did budgetary adjustment. To let know that nearly all the mechanism was used by the government to develop strategies. This was not sufficient. We did more. The government put in place special fund for the response. COVID-19 fund is about $1 billion that was used by the country in a multisectoral approach, but all based on the impact on health and economy. One other mechanism was the response preparedness plan fund, the multisectoral contingency plan I talk about, and special measure to facilitate procurement related to the fight against COVID-19. This one was a load a bit for the health system in terms of going quickly in the resources. But the special measure helped to do a lot, to buy quickly cars, ambulances, to put in place, a treatment center, to put in place human resources and so on. This measure was very special and important. Slide, please. So we can share here the costs. What came from this measure. As I said, in terms of special funds established for the response, COVID-19 fund was nearly $2 billion. It's very important resources for that. The contingency plan, $116 million, and the preparatory phase, $2 million, $2.5 million. The private sector at this stage did participate about $2 million US. Communities and individual donation were about $2 million. And in here you have the territories like, the mayor and all the, civil society and all of that. Slide, please. So how to manage? Because all these resources should be managed with transparency, because we want to go quick. And when you want to go quick, sometimes you need to shorten things, and you need to be transparent in a way not to having some problems at the end of the day. And on that, we put in place mechanism like at the central level, more commitment and more involvement of the CNG, which is the National Health Committee, which was defining the priorities and given like an order, what is not usual. Usually we have the financial department of the ministry and the Ministry of Finance, according to rules established. This time, the Senegal were able to say, we need that, we need this in a shorter time. And it was like a way to have this in a due time. But this was related, as I said, to priorities. We create, new mechanism procedure for disbursement with the implementation of the first COVID-19, which was based at the head of state office, and help as well to take decision and make action in a quite short while, time. At the regional level, we had nearly the same around the governor for prioritization, follow-up, and control. And the governor were able to say, we need this for the hotels, like we need this for the treatment and so on. They get the money and then give feedback and show it in a very transparent way for most of the case. Slide, please. I wouldn't talk only about, domestic resource mobilization. We're gonna show what happens with external partners as well. I show an example of World Bank because there was very specific mechanism which are really official and that need and which need to sign convention quickly with the state or the government of Senegal. I can list the pandemic emergency financing facility. Those of some of you know that the PEF, activation of contingency emergency response campaign, and the CATDDO, which is as well a disaster mechanism to get funds. We use two of them, and that was very, very helpful to buy and to organize the fight against this pandemic. All other partners, United Nations, multilateral, bilateral, and all the partners, they as well, according to mechanism, their own mechanism in relation with the government, they put in place nearly $86 million. But it was not only about giving money, it was as well about giving some technical support in kind. If I take the example of, health system strengthening USAID mechanism, so they intervene in 7 regions out of the 14 regions for nearly $3.5 million. It was not only about, the pandemic, but how the services would go on as well. So how to prepare for the post-pandemic. So this is, very interesting, and each of them has a special history on that. Slide, please. We learn a lot of lessons. We can share some of them. The availability of documents. You need to have the documents in time, even before the pandemics, before these things to happen. How to provide emergency resources and act on priorities. That is something you need to think about, the perspective. How to activate, the partner emergency funding. It was well doing with the partner in collaboration, and we had good results on that. The involvement of the private sector and local authority were very, very important, not only in resources, but in advocacy and everything. How to mobilize community organization and community leaders. This is key in this kind of pandemics and epidemics. And how to develop multisectoral approach for the COVID-19 with line ministries, private sector, civil society, and all others. This was done, and this was very great. And that's something to think about. And we learn a lot about all this process, and we're gonna share it in multiple ways as well. But we don't think that, slides, please. We wouldn't say that everything was working. We have evaluated the 6 months period. There are a lot of gaps in terms of health system approach, in terms of needs, in terms of human resources, and in terms of perspective. And the most important thing is the head of state decide to say, okay, we need an investment plan for a resilient health system. We need to be proactive and prospective because of the recurrence of health emergencies, socioeconomic impact, need for long-term planning. We need this, very, very important. But it's not only about putting in place an investment plan and make it happen. It's as well about having reform, very important reform. So to be efficient and to be proactive, but as well to have the most we need from the, from the health sector, and the most, in terms of benefits from the community. Mostly the reform is gonna be around the hospital governance, around the private sector management, which is very, very important, and around the supply chain. We have other in district reform that's going to be done, and mostly reform in a national health plan. Slide, please. So thank you very much. Shortly, we try to share the experience. So we are looking forward to getting any question. Thank you.
Thank you, Dr. Yusufa. That's very interesting experience there. I think I noted the multisectoral way that Senegal tackled this epidemic and the DRM part of it. And I think, as you said, lesson learned would be how do we adapt that model to be able to tackle more of other health system issues. So the multisectoral way of going about these issues is very important, and thanks for that experience. I think now that we heard from all of our presenters, we'll now move to the part of our session that is going to facilitate a discussion between the panelists, but also take questions from the audience. So if you have any question, please use the chat, the Q&A function on your platform, and keep asking those questions. I will now turn it over to Kelly Saldana for the panel discussion piece of our session. So over to you, Kelly.
Thank you, Sophie. Good morning, good afternoon, good evening, everyone joining the session from around the world. I want to thank Apt Associates for hosting the session, and the wonderful panel of speakers for sharing their country's experiences with health financing. Those presentations really demonstrate why this conference is meaningful for sharing successes, lessons learned, and exchanging ideas, particularly for ways to engage and collaborate across the public, private, and civil society and community sectors. I'm really looking forward to delving a little deeper into each of these experiences in the discussion. As we confront COVID-19 pandemic, it's important now more than ever to have open dialogue that raises the awareness for the importance of sustainable domestic financing as a pathway to self-reliance. While donor spending remains a critical source of financing for health, in most of the countries where USAID works in recent years, we've seen growth in government spending that outpaces other sources of financing. This is an encouraging trend given the importance of public spending for access to universal health coverage. However, we also recognize that COVID-19 has put these strides at risk. Many countries are experiencing shrinking economies, which means that public financing for health will decline without active reprioritization. The UN and the World Bank expect foreign direct investment to plunge by up to 620 billion, or 40%, and remittance flows are expected to fall by almost 20% globally. The IMF is projecting low growth this year in many developing countries, and especially in the lower middle income countries where the World Bank predicts economic contractions. To the extent that private financing, either from domestic or foreign investors, can supplement public financing in a sustainable manner, this would be the time to collaborate more with the private sector to ensure that important gains in health outcomes aren't lost. Of course, regardless whether there's a pandemic, investment from any source should always be sustainable. So USAID is examining how we need to adjust our work in a world altered by the COVID-19 pandemic so that health systems are more resilient and so that health outcomes we have achieved are not lost. The economic fallout from the pandemic increases pressure on already strained health systems and has implications for millions of people's access to healthcare as they face potentially catastrophic financial risk and limited available essential healthcare services. The presentations we've heard really shine a light on ways countries are adapting to meet the challenges presented by the pandemic, and also planning in sustainable ways to continue to fund their healthcare and to continuously improve their health systems. Finding ways to more efficiently and effectively use available financial resources is fundamental for building a health system that provides healthcare to all people when they need it at an affordable cost and within a reasonable distance. So far, we've heard how optimizing funding flows in Tanzania has led to better facility management and more effective service delivery. We've heard how public sector in Kenya is increasingly looking to the private sector for ways to increase domestic revenue. And we've heard how in Senegal, a multisectoral approach helped the government quickly assess its health system capacity and needs to move funding to where it was needed most to address the COVID-19 pandemic. With that, I'd like to once again thank Mr. Katali, Dr. Tuli, Mr. Mbogo, and Dr. Yusufa for joining us for this panel discussion to share their experience. We're also joined on the panel by Joe Cutson from WHO. So let's get started with our discussion. I think we have about 45 minutes, so hopefully we'll have a very rich discussion during which I will ask the panelists a series of different questions. We'll also take questions from the audience, so please go ahead and submit your questions in the chat box. To get us started, let me start again with Dr. Tuli from Tanzania. Could you talk a little bit more about why the direct facility financing is important to Tanzania and to the citizens of Tanzania, and also what you see are the important lessons learned that might be relevant to other countries around the world?
Thank you very much, Kelly, actually, for a very important question. The director's facility financing, as I said, that emanated from a meeting which was held in December 2016. So one of the things which were observed prior to its introduction was there were misappropriation of funds at the district level, and also there were delays in disbursement of funds which arrived from a Ministry of Finance to the district level. So the government of Tanzania decided now to send money direct to the primary health facilities. And in so doing, it has helped to enhance accountability at the primary healthcare facility level, because these primary healthcare facility level, they've got governance structures, which is composed of people from the community, which we call the Health Facility Governing Committee. With the chairperson to the committee is someone from the community. The secretary is a health facility in charge, and the remaining members are also coming from the community, while the secretariat to it are also the members of healthcare facilities. And these are mainly responsible with endorsement of all the transaction at the public primary health facilities. And this has helped the issue of accountability and also transparency of whatever cents which is collected at the healthcare facilities. So for us, after introduction of the public primary health facility, what we have witnessed is that there has been now constant supply of health commodities at health facilities, because now these are granted autonomy to be able to procure some commodities within a certain threshold. And if you exceed that threshold, then you need to get some approval from the district authority. So that has helped with all these minor rehabilitation of health facilities, incentive package at the healthcare facility. All these ones have contributed to improvement in health service delivered at the primary healthcare facilities. But the lessons which we have learned is that when we started this initiative, we also employed the assistant accountants who are working at health center level. And these are the ones also who are assisting the dispensaries within their satellite areas to manage their books and also other things. So what we have learned is very important, every and each facility to have an assistant accountant, because in the areas where dispensaries are very far from the health centers, they haven't been able really to manage well the finances. But for those which are close to the health centers, they've been able to manage finances properly. That's one. Two is that you need to have very strong health facility governing committees, and these, as I said, composed of the members of the community. So there is high level of accountability. But prior to these teams to be able to carry out their responsibility, you need to capacitate them on how to make sure that they hold to account the teams at healthcare facilities. And also you need to make sure that you get feedback, frequent feedbacks from them, for them to be able to discharge their duties accordingly. So the lessons learned from this initiative, you need to have very strong health facility governing committees, and also you need to have assistant accountants at all healthcare facilities for you to be able to really appreciate the effects of direct health facility financing.
Great, thanks. And maybe just to take a question from the chat, because you mentioned the procurement of drugs and supplies, could you comment on whether or not there are economies of scale by providing autonomy to the facilities to procure their own drugs and supplies, or do you see a difference in the cost that the facilities have to pay to procure the drugs and supplies?
Indeed, indeed. So prior to the introduction, what we learned is that everything was actually procured at the district level. They were over-reliant to the district authorities to be able to procure on behalf of healthcare facilities. And that caused a lot of delays. The lead time went up to 2 months, 3 months. The facility would have maybe money, but they could not really go and procure these health commodities. But after introduction, when they were granted the autonomy to be able to procure up to a certain threshold, and when they were given guidelines, what we have learned now, most of the facilities, they have got plenty of medicines and supplies, and they can decide on so many things, including minor rehabilitation, allowance provision as part of incentivization to the primary healthcare facilities. So for us, we feel that this is something which need to be more strengthened. However, the challenge which we have, and we are working on it, is to have robust and really very strong monitoring and evaluation framework.
Thank you. My next question maybe for Mbogo. I think you describe your partnership as a CSR, corporate social responsibility partnership. I think it's probably more than that. I think that there is a lot of incentive on the part of the Twinnings partnership as well as the community to participate in this, not just for corporate social responsibility, but also for their own corporate objectives. But could you expand perhaps a little bit on what are the opportunities across the public sector to engage private sector-led facilities and private sector entities for these shared purposes, where it's not just a donation program, but really is working to improve both the private sector bottom line as well as the public sector goals?
Thank you, Kelly. Yes, I do agree that one, it is not just plain or simple corporate social responsibility, and in fact now the most current thinking, or the more current thinking of how corporates are looking at this, is how do I ensure sustainability for the business, which is a good thing, and are now looking at this as corporate social investments or corporate investment partnerships in ways that, one, it is possible to do good and still make a profit at the same time. So I totally agree. It's not only tokenism in terms of, hey, here, get a bit of this or the other, but looking at how do I make investments that benefit the communities I work in, as well as support my bottom line, because ultimately they need to be in business to continue doing this kind of support that they're making. So agreed, totally on that. And other ways that these can be tapped into is looking at one, investments that corporates are making, and I'm looking now specifically within the healthcare. So supporting private capital investments that corporates may have made in this is a way that we can unlock more. It takes significant initial investment by many social enterprises to address both underserved populations or hard to reach populations. And there are ways that both donors and governments can support these kind of investments. And one of those is in terms of matchmaking. So there are certain investors who are investing in one area and looking, say, for markets from other areas, and there could be matchmaking that, given the position that governments and donors sit in, they can see this and can connect and create an enabling environment for that to happen. And with that comes the growth of the enterprise. And after that, then they need lending and they need credit to help them grow further and continue to be able to provide these services. And on that aspect, then specifically partners and development partners can help structure better or positive lending arrangements by trying to reduce the risk to commercial lenders, and that can help these private sector entities then grow further. So I think that's one other area that corporates can be supported specifically within the sector. And if we're looking beyond the health sector, like we did with Twinings, it goes back to the aligning incentives perspectives and looking at, great, what a healthy, say, internal workforce is a plus for a corporate entity. And we find that, for example, employees internally are looking for companies that are more sensitive, so starting internally, to needs of the community. Number two, it does help companies have what's the word, softer brand or more connectable brand. So it also gives them a responsive kind of look and feel, which is good. And so if they do that and increase the bottom line, and we are getting more resources for healthcare for our priorities, then it's a win-win. So I look at that as sitting and really thinking more critically about how will this investment have a return to the companies and a return for public health.
Great, thank you. And I want to bring in Dr. Youssoufa to this conversation. I think you shared a great example of a multisectoral response to COVID. And I'm wondering if you could talk a little bit about what factors were effective in mobilizing the different stakeholders in this response. Were they already mobilized and connected, or did they really step up to the plate in response to COVID?
Thank you very much. I mean, to me, we have at least three main points we should care about. One is we shouldn't wait for this happening to make it done. We need to think about the multisectoral approach. At the Ministry of Health, what we've done, we identify all the determinants of health. And for each of them, we identify the stakeholder, which is the best one for that. And then we create this multisectoral under the cover of the cabinet, the presidential cabinet. Once you have done so, it's very important to have strategic documents, because we need, like the COES, which is the Health Operational Emergency Center in Senegal, between the two pandemics, Ebola and this one, they work on that as well to say, okay, if this happens, we need this kind of resources, we need this kind of stakeholders. And when it happens very quickly, you can put in place your strategy and put in place the list of people you need. And another thing is the regular meeting, but not only meeting with very clear objectives, and the resources, when they decide something as a multisectoral, a multisectoral organization, they need to have response. If we decide in this approach 1, 2, 3, 4 times and nothing is done, it's gonna die by this way. So this aspect is very, very important. Regular meeting and things being done at the end of the day. So just these 3 or 4 to share with you.
Great, thank you. And maybe back to Tanzania and Eric, the public financial management system and the district financing facility in Tanzania is also multisectoral. It cuts across both health and education. Did you find that was is useful in organizing and collaborating in a multisectoral way? And could you perhaps talk a little bit more in detail about that? Over to Eric.
Yeah, thank you, Kelly. Actually, when you talk about health sector, it doesn't stand by its own, because it has to deal with other sectors like education, water, and planning, revenue, and all those. So in Tanzania, when you build these systems, we look at system approach, holistic approach, whereby we ensure whatever we are doing can be used by other sectors. And when we do the planning, actually before 2017, the system which we are using, it was kind of fragmented sector-wise. And after 2017, we ensure the system which we developed, it covers all sectors, because as I said, the health sector covers everything: water, education, etc., etc. And as I even shared in the chat here, the system we developed in 1 year. We do the design, the development, the deployment, and the use. And we see a lot of benefits using this system. Actually, the system has been locally developed by our local experts, and the costing for planning doesn't really matter if it's only health or education, but cost for planning, the planning session, it was around $4 million US. But after using the system, cut to 50% to $2 million US. So you find all these monies which are being used to only for planning has been transferred to other activities and services. But also we are using more than almost 8 months doing only the planning and budgeting. But now we are using less than a month doing the planning and budgeting, because everything is online. Everybody, wherever he is or she is, can just do the planning and budgeting, and it's all data just to the central level. Over to you, thank you.
Well, Ibrahim, Alhamdulillah.
So great, thank you. I'm gonna maybe ask Joe to weigh in here. I know your team does a lot of work on health financing in general, and I just wonder, what are some of the best practices globally, or some of the key lessons about this multisectoral financing approach, and multisectoral not only of government funding across sectors, but also the inclusion of private and community financing, and how that all comes together.
Thanks, and thanks for having me in this session. I think one of the important things, maybe just to follow on from the point that Eric made, but let me start by saying we do need to learn a lot more about these multisectoral approaches. What strikes me in the Tanzania experience as really important from an implementation perspective relates to the last question you gave, which is that basically, because this is a reform and a public finance management reform that is not just for the health sector, but cuts across many sectors, it may lower the resistance of the finance authorities to doing something that is just a special favor to health. And we tend to ask a lot of special favors about how different and important we are. And my guess, maybe the Tanzanian colleagues can have their perspective on this, but I think that the fact that this was not just for health, but across multiple sectors, probably made it more interesting for the government to kind of take that type of approach. So I think, I'll come back to some of your other questions, but I'm just curious, asking the two Tanzanian colleagues if that was the case, because I think it is an important lesson in thinking about implementation. We're also trying to be a bit more interactive if we can.
Sure, no, would either of the Tanzanian colleagues like to comment on that?
Let me start and Dr. Ntuli take over. Actually, Joe, you're coming from WHO, I guess. And when we are building systems in Tanzania, we normally follow WHO healthy system building blocks, where we have the human resource for health, health financing, planning, leadership and governance, supplies and medicines, all those. But when we develop a system, we ensure we touch all those 6 building blocks, because as I said, you cannot say just human resource for health without planning or financing or leadership and governance. So whatever which we are building right now, it's just touching all those. And as Muungano Gateway, our mediator, we ensure now all these systems which we have developed, like expenditure system, planning system, HSR for health, and all those are just coming together, integrated by Muungano Gateway. And at the top here, we just manage any data at the central level, which we can just do the monitoring and evaluation towards the dispensary. Over to you, Dr. Ntuli.
Thank you very much, and thank you very much, Eric, and thank you very much, Joy. And I've been one of you, the people have been using a lot of references from Joy. So I'm very glad to have him in this panel. And adding to what Mr. Eric has said, that in Tanzania, most of the systems are guided by the WHO framework, so as the directives facility financing. That's why even the studies which we conducted around the DHFF, we made sure that we touched each and every building block from the WHO. For instance, in the part of the service delivery, we went into the structural quality. We were very much interested with the structural quality in terms of the staffing level, the medical equipment, health commodities, and other things. Before, and we compared it after, while we were controlling for some other factors. And what we learned, really, there were a significant change after the introduction of the directives facility financing. And we were conducted some interviews to the healthcare workers to try to learn from them what they feel after the introduction. They were able really, as you could see from one of our slides, that they feel this is something which is good for them because it has reduced delays, and also it has helped them to make decisions on their own. But the good thing maybe starting with different sectors, education sector started before health sector. So we had to learn a lot from the education sector as well, the do's and the don'ts. And of course, the Kenyan's colleague, they started prior to us. So we had also to learn from Kenya, although we have modified some of the things because, you know, they use a devolved account system. For us, it's similar to Kenyan system, but slight some differences. So we had different experiences from the results-based financing, a program which is implemented in 8 regions in Tanzania and more than 48 countries in African continent. So we have this hybrid of things from different programs, which has helped us to come up with something which is very robust, and we feel this is something which can be learned from other countries as well.
Great. Maybe, Kelly, if I could respond maybe more broadly to your question. I mean, I think that many people are aware that we have put out what we call some guiding principles in terms of health financing for UHC. And those really, I mean, in a nutshell, are basically that countries do need to rely mainly on public or compulsory sources of funds, which is really some form of taxation. And in low and middle income countries, that will tend to be indirect taxation. So not direct contributions for health coverage, but also to reduce fragmentation, to drive change through efficiency gains, often with strategic purchasing, to align benefits and so on. So the issues, I think one of the critical challenges, of course, is that there is never enough money. And Kelly, as you said, the context of COVID makes it much more difficult given the macro fiscal outlook. So I think a few things there. One is that it's really clear that we have not, with all the best intentions, and perhaps with the exception of Senegal, countries have really not given enough attention to public health and preparedness to the extent they should. We have talked about UHC as including not only personal services, but population-based services, but it's not clear that we and many others have done more than talk about that. And it was quite clear that a lot of countries were not prepared. What we heard, and again, the Senegal case makes really clear, is that it's not just a health preparation, but your public finance systems to be able to receive and reallocate funding quickly, I think is really an important dimension. We will have to pay more attention to efficiency in terms of getting the most out of limited resources, including ensuring that the response to COVID and future challenges is not run as a vertical program, but really as a cross-cutting health systems response, and looking to put things really in a way that for a population-based response, you need population-based underlying systems around data systems, your surveillance systems and so on, and not organizing those by health scheme or health program. The private side of this, I think, is a challenge. And in a way, for me, from my perspective, it's possible for private financing to play a complementary role. But whenever we say that, for something to be complementary, it means that there has to be clarity on what public financing is for. In other words, private financing is going to happen one way or another. As incomes grow, it will increase, and now we're potentially going to see a situation where private financing will fall and service use will fall, right, as a consequence of COVID. So it's still really critical to get clarity on what is it that public finance is paying for and define the space in a way that private financing might fill, rather than having that private financing occurring in fairly random, uncoordinated ways. So I think that's kind of a critical challenge as well going forward. Let me stop there because there's probably a lot more questions and things to say.
Sure, thanks. I think there's a question in the comments about accountability, and I think Dr. Youssoufa in particular talked a lot about prioritization, and I think this builds a little bit on what you're saying, Joe, in the sense that we need to have overall, prioritization, and to the extent that there's a consensus across the country about what we're prioritizing, that almost feeds into being able to affect accountability a little bit more. If the prioritization is misaligned with what citizens want or are interested in, it could have an impact on accountability mechanisms. So maybe Dr. Youssoufa, if you want to take that question and just talk a little bit about what you feel, you talked before about prioritization, but whether or not there is an accountability aspect to that, and whether or not how citizens in Senegal have responded to these efforts and in alignment of those priorities.
Okay. Talking first about prioritization, it won't come from nowhere. As I said, it's very, very important for countries to have prospective documents. When the first day we learned about COVID-19 in China, in the same week, it was about discussing what would be done to prepare ourselves for COVID-19 to come first. And then when it comes, what would be done to make this not growing up so much. And in this way, in the first document, it was, as I show you, what are the main issues in which we should prepare ourselves? What are the main criteria that are going to help us to prioritize? We talk about surveillance, we talk about many, many, many other issues. And that was the way to say, okay, on the operational field, these are where we should put more efforts and more resources. Talking about the community, I mean, the priority of the community is not to be ill, not to die from illness. So they were putting a lot of pressure because each community has its own specificity. And the way we did to minimize this was to put the same scheme at the community level. When I say the community level, is at the local community level, at the departmental level, and at the regional level with the governor, the prefect, and the sub-prefect. And around them, we have all the different branches of the community, civil society, local private sector, whatever. And they were working on the prioritization for the community, for the department, for the region. And this was, sent to the national government, and the decision to give resources was done there as well. I don't know if I answer your question, but that are 2 points I would develop.
I think so. Maybe I'll bring in Mogo a little bit more on this accountability aspect. I think in a public-private partnership, there's probably interesting accountability dynamics in terms of everybody sort of holding faith to the overall partnership. So I don't know if you wanted to comment on that a little bit.
Okay, I'm sorry. So in terms of accountability, as I said, that was the main question. Okay, the government gonna put things easier to spend the money. It seems it could be easier to do something else, which is not, which is prohibited. And for that, the government put in place what I say, first COVID-19, it was not about giving the money. At the head, it was one, a person who morally is very respected in the country, who is a general in the army, and who choose people like him in all departments, so as they were able to say, okay, at a ministry, tomorrow we cannot be in your ministry to look at all happening in terms of spending the money, in terms of using the money, and they did it. That's something you can see on internet if you like. So this is just one aspect. The same thing was put in place in the region, because the governor was working with all the financial, department to look after this at different level. You can't reassure to 100% it was okay everywhere, but this was done. And the public-private partnership, we had a chance, I say hi to my friend from Shops Plus, because we had as well Shops Plus this last 5 years in Senegal, and they helped a lot to develop the public-private partnership. Before the pandemic to happen, we have what we call a document of orientation in public-private partnership in Senegal. And the first document was given by the Minister of Health, even before the Minister of Finance. This is due to the collaboration with Shops Plus. So we had a platform of public-private partnership, and we use this platform during the epidemics so as to go faster. Yeah.
Great, thank you for that additional detail. And Mobo, do you have any anything further to add from the Kenya experience?
Yes, I do. And Yusuf, thanks. I received the greetings and glad to hear we're working together in Senegal as well. Sure. Sure. So Kelly, for accountability when working with the private sector and multiple partners, it is a drawn-out process, and I think a repetitive process of bringing people together transparently. And often that needs a credible or an honest broker, some sort of facilitator that can be trusted. And in my view, I think players like yourselves, like the donors, can help fill that space. So people who, when they sit around the table, I think Yusuf talked a bit about the reputation or the character of the facilitator that brings people together, can then say, let's come together to address this issue, and I will be sharing the information in a balanced or in a fair, and because there are of course other questions of intellectual property and information sharing amongst private sector, but with a credible facilitator consistently meeting and sharing information, you can help make accountability clear, because you will state, this is the goal we want to get, these are the gaps that need to be met, this is what I have received from X, Y, and Z, and this is how this is going to go forward. So accountability is a repetitive, drawn-out process of bringing the partners to the table through one, ideally, in my view, one independent party that can speak, that everyone else can respect and can think that this will be shared in equal manner. So that's my take. Thank you.
Kelly, can you unmute, please? Kelly, can you unmute, please?
No conference is complete until we say you need to unmute.
Sorry, I thought I had unmuted, but I guess I didn't. So I was just trying to read a question from the audience, which I think is probably best for you, Joe. It says, how can health financing schemes be reimagined or re-engineered in settings that are substantially aid dependent?
It's a very tough question, but I think that we need to focus, I think, in the first instance in building some of the underlying systems. I mean, I'm very impressed by the Tanzania experience, because I think that this has captured a lot of what needs to be done. I mean, it's critical to focus in the first instance on making budgets more effective, right? And that means the kind of PFM work that has been undertaken there that and allows even, not with huge amount of money, but they're paying for outputs and not just inputs. They've moved away from line item controls and so on. And these are things, and I think critically have provided all the support systems for this. So one thing I think that's important to remember is that the health financing community is not going to solve the revenue problem, right? That's outside of our space. The revenue problem will be addressed from finance ministries and overall economic development and overall tax policy. So it's our job to make the money more effective, to use it better. And in that sense, even in aid-dependent countries, it's possible to make positive changes in the engineering of the system, which I would think is a way of characterizing what's happened in Tanzania. I know years ago, the experience in Burundi, where in response to a presidential decree to make services in health clinics free for mothers and children, yes, most of that response in shifting towards a performance-based financing approach for those free services, most of that was initially and maybe is still funded externally. But they also changed the process by which budgets are formed to enable that to kind of be reflected in the program budget. And these things, even as whatever is happening with the external funding is moving, we need to focus on building those systems. I think another aspect which is really critical underlying this, and this is something that increasingly all countries can do with the sophistication of information technology, is trying to make data systems either interoperable or unified, but effectively unified. And I think this is, again, critical in both preparedness and response as well. So even if your system has small insurance schemes or multiple funds or however that is done, it should be within the scope of regulatory authority of the health ministry to ensure a common patient discharge form, for example, to enable a common database where someone's insurance or exemption status is just one field on the same form rather than in an entirely separate data system. This is really important to think about. How do we build, even before even before it's possible to have a unified, universal health financing system with a nice benefit package for everyone, what are the elements of universality that can be built in? And I think the data systems and the PFM arrangements are critical there. It's also possible to think about how to frame, let's say, some of the vertical program services as well. So you would never want to have, for example, HIV or TB services just for the insured, right? Those need to be universal. We need to think about how does strategic purchasing work for those, but it's not necessary in all cases to run them as completely parallel systems. So trying to think about how to design in elements of universality. And I think that those things are not just from an equity perspective or a UHC perspective, it's critically from an efficiency and preparedness perspective as well, that those types of steps are needed. So I would just say, I mean, I usually talk too much, but just to say that thinking about how to design in elements of universality from the beginning, and thinking about the changes in the engineering of financing public finance systems, again, like that we heard about in Tanzania, are really important steps to consider. Thanks.
Thank you. So we have about 7 minutes left for the discussion. So I think maybe I will run through all of our panelists for their final thoughts. And if you could comment on the theme of this session is a sustainable financing for self-reliance. And so I think given the COVID circumstances and the strains on all of our health systems, but taking that in the context of the wonderful examples you've shared, what are your biggest hopes for how you can translate this into something that is sustainable and really helps to put your countries on a path towards self-reliance, and then whatever other final parting comments you might have. Let's start with Eric.
Thank you, Kelly. I will talk about the ICT side, and Dr. Antul will talk about the business side, the medical. I have three issues. One, as Joe said, money has never been even in developed countries. So we have to make sure we put machinery which can effectively and efficiently manage whatever we have, whatever little we have. And in Tanzania, the system which we are developing and we are deploying to the facilities and the community, we ensure full participation of the people, transparency of whatever which we are doing, like budgetary plans. You have to make sure we put them to the public, and the accountability and reporting. If people have been participated, everything is transparent, even the accountability is easier, even the response from the community is easier. That's number one. Number two, the take home from my colleagues across the world is that whenever we are doing systems in Tanzania, whether it's DHFF, whether it's ICT systems, we don't do small pieces. We don't go for pilot. Actually, in Tanzania back then, we do have a disease called the pilotitis. Every single day we keep on piloting. In Tanzania now, the program is go full-fledged, big bang. Like here, we have 26,000 plus facilities in a year deployed with the system. So the pilot system, there's no room in Tanzania. That's number two. Number three, the last one is whatever we are doing, we embrace on the Kaizen principle, the Japanese principle, continuous improvement. We don't reinvent the wheel, we don't duplicate, but we keep on improving wherever we are. And whatever we are doing as far as systems are concerned, ICT systems, we avoid vendor locking, partner locking, technological locking. So we are free to make sure whatever we are doing is sustainable, we can improve, we can maintain for the future. Thank you very much. Over to you, Kelly.
Great, thank you. Over to Dr. Tully.
Thank you very much, Kelly, and I would like really to appreciate my colleague, Eric. Indeed, for us to be able to move, we really need to invest on the primary healthcare, to have strong institutions at the local level, to have strong governance structure. The health facility governing committees need to be very strong, need to be robust for us to be able to implement whatever reforms which we have. So for the Tanzanian, from the Tanzanian presentation, what you have learned that we really need to make sure that we have very strong information system. For instance, the facility financial accounting and reporting system, we can have real-time data from more than 6,000 health facilities across the country. And that is very important for us when it comes to the issue of accountability. And when it comes to accountability at the facility level, particularly primary health facilities, we have this interface meeting between the members of the communities and the health facilities members. And also these are the ones who participate in from planning and budgeting, implementation of the budgeting, so as the reporting. So this has to be well institutionalized at different level for us to be able to really appreciate whatever reform which you have started. We have had a number of reforms in the past, but this one proven to be one of its kind, because now we are able to really appreciate the changes it has brought to the healthcare system, particularly to the primary healthcare facilities, which is a gateway to more than 95% of Tanzanians. So this is something which I really would like to leave as a take-home message to those who are participating in this meeting. Thank you very much, Madam Kelly.
Thank you. Mogo?
Thank you, Kelly. So I think what I want to leave us with is, as we appreciate and recognize that the goals we have far outstrip the resources available, we then can align or tap into companies that are also looking at sustainability as a long-term strategy for their businesses, and seeing how these development goals can feed back into their own sustainability. And at the same time, look at investors and lenders who are looking, of course, to have more stable business environments, to have more stable environments from which they can get returns. And then players like international development agencies, governments, who are the actual stakeholders, can then see how do we bring these three interests together to bridge the gap that we have got to get us towards UHC. So just leaving the party show that I think this is a ripe time that all sectors are looking at sustainability, and what remains is the facilitation to align and see how they come together. Thank you.
Thank you very much. Dr. Yusufa.
Thank you very much. I mean, for sustainability and self-reliance, we need to go ahead the principle of universal health coverage. It's very important. As he said, we need to revitalize the primary health care, because in Africa, we have more space for hospitals, and we need to do more in primary health care. We need reforms of the health system, but reforms in the procedure and the financial procedure, allocation of resources, everything. We need reforms on that we're thinking about. The human resources are key. We can't succeed if we don't have real human resources. We need to put a lot of resources on that so as to get them ready for that. We need more money, more investment, more domestic resources. We need investment plan. In Senegal, and other countries, we have started an investment plan to have a resilient health system. It needs to be adapted. We need social protection. We won't forget social protection. We're only talking about services. We need social protection so as to have a balance. And lastly, not exhaustively, we need a better governance and the tools for governance in terms of health system, information system, digital health, gender approach, and more. But we need this at least. And we need, at the end of the day, perspective. We won't wait for things happening. We need to think about. Thank you.
Thank you. I'm going to turn it back over to Eric for one final quick point, and then we'll give it to Joe for his concluding remarks.
Thank you, Kelly. Actually, Kelly, what you have done in Tanzania, people might wonder how was it possible, and thinking maybe the size of Tanzania is very small. I just want to emphasize that Tanzania is bigger as Germany times 3, Italy times 3, California times 2, Texas times 1.5. And we managed to put all this in a year, regardless of the challenges we have in electrification, network, and all those. So it is possible, or to whatever you have. The best thing here is to have the machinery, government machinery, which are very sustainable and robust and visionary. Thank you, Kelly.
Thank you. Very important context, and really does highlight your achievements. I want to thank all of the panelists. I think this has been a really robust discussion. I learned a lot. I look forward to continuing to learn. But before we conclude, I'm going to turn it over to Joe to give us the final concluding remarks.
Thanks, Kelly, and thanks to everybody. I also learned a lot in this session. Some things I had some familiarity with, others not, and there are a lot of good examples from this. What I'm going to say now, just just for the audience and others, I'm going to make reference to a few documents, blogs, and things. I put all the links in the discussion forum section for this, so you can see those there, and hopefully can do some clicking after the session is over. So just a few things in terms of, how to deal with sustainable financing. I mean, even during normal times, it's a challenge, right? And especially for low and middle income countries with high informality and limited fiscal capacity. And it's going to be more challenging because of the expected implications for both income and especially for public finance of what COVID is likely to bring. And while that's the case, it doesn't mean that we throw out what we already know about health financing. I mean, this is a health systems research conference, and there's 30 or more years of evidence, which is strongly backed by economic theory, about the importance of public funding, the weaknesses of voluntary prepayment, and so on. Obviously, it's a big problem to rely too much on out-of-pocket spending. But it is a real issue, and as I said, the COVID context may mean that actually we could see a reduction in out-of-pocket spending, but that's not necessarily a good thing in the sense if it just means there's less services being used, okay? The issues with voluntary health insurance, which is really different from the type of private financing that we were talking about in this session, so I'll come back to that as well. In general, in countries, it doesn't raise a lot of money. And where it does, and I'm thinking specifically more in Southern Africa, to some extent in Kenya as well, it can be a key driver of inequity and inefficiency. So it can raise a lot of money, but it does so in a way that actually doesn't close any funding gaps for UHC, and arguably has widened some of those gaps by drawing off scarce human resources to serve the privately insured. I think the bigger issue here, whenever we look at all of those funding gaps that we and other organizations produce, is to not let people think that health financing is just an accounting problem, is just trying to solve an accounting problem, right? So it's a big challenge. And this combination is a problem, right? Because the reality of what works in terms of financing sources for UHC and the context of high informality and low fiscal capacity can really put us in a bind. But what we heard is that dealing with this requires a multi-pronged approach, dealing with the revenue side, but then also, and part of that is a health financing framework that actually doesn't just talk about private financing being complementary, but sets up a framework in which that can happen. And then critically, an efficiency agenda. Now, these are not easy, but we've heard some promising ways forward. And I think what I want to emphasize is that at the top of the efficiency agenda are the kinds of actions needed to enable both better and more flexible use of funds. One of our many slogans is, no country can just spend its weight to UHC. So it's really why a focus on improving public financial management is so critical. And we heard a lot about that in both the Tanzania and Senegal cases. We've spoken a lot, there's been a lot of questions about the Tanzania DFF experience. I just wanted to say again, it's really interesting and quite influential. A lot of countries and agencies are paying attention to this. And I really want to congratulate the government of Tanzania, USAID and APP's PS3 project for this work, because it really embeds a lot of critical aims in health financing with important kind of lessons on how to do things. Critically, it's about enabling providers to directly receive, manage, and account for funds. And before, some countries, this was partially possible, but just for, say, user fee income. But it's really been critical to make budget funds as attractive to facility managers as user fee income, so they pay more attention to the budget funds, right? And combining more autonomy with the support and the systems to enable accountability has been critical. So at its core, this is a PFM reform. I mean, Eric mentioned earlier that we don't pilot. And in a way, one of the key distinctions between a reform pilot and real reform implementation is whether you've changed the PFM system, right? Whether you're embedding this reform within your budget and your national system processes. And the Tanzania experience really illustrates both how to do it and that it can be done, right? On provider payment side, it's also moved towards something we think is really important as an indicator of progress, which is to move away from top-down hierarchical budgets or just reimbursing providers or setting tariffs and putting in place a formula-based payment system with policy variables that you can adapt that deal with equity considerations, utilization concerns, and that's an adaptable system that's in place there. They've defined enablers for implementation, interoperable systems, a whole range of things we heard about. And at the end of the day, it's about letting managers manage and providing real rather than rhetorical support to primary healthcare. Now, one thing that is on the revenue side, PFM we typically talk about from an efficiency perspective. But it also has a spending side. It enables better execution of funds when you have this type of flexibility, when you eliminate or reduce line item controls, allow the managers to address immediate needs. We all know in many countries where the Ministry of Health may go to the finance ministry asking for a larger budget, and finance says, well, why should we give you more? You didn't spend what you had. So one of the blogs that I cited was something that my colleague Helen Barwa did with Sanjeev Gupta of Center for Global Development, really draws out the links between effective PFM and fiscal space for health, right? So this is really an important dimension we need to look at, not just in, it's very important, obviously, to improve efficiency, but also in terms of getting better use of the money we have, okay? And ultimately, then I wanted to just say something quickly. We've also looked at the issues around the COVID response. And the example from Senegal was great. It really resonated with some of the work we've also been looking at in terms of how this might be an opportunity to accelerate PFM reforms in the system, how to change the spending modalities, and again, to kind of still pay attention to some of the accountability issues as well. We have done a review with the IMF of things like the Senegal experience with these establishment of separate COVID-19 funds. They have pros and cons. There's concerns a little bit about fragmentation, but with care, they can really provide a positive experience. And that's, I think, what we're seeing in Tanzania. On the private financing in the Kenya case around philanthropy and this and corporate social responsibility, but really the specific case about finding this common interest between the companies, the D companies, and the local population, it really looked like a kind of locally driven approach to fill small but really important gaps within an overall niche, an overall comprehensive approach to community and health development. So it's small, but it's a very important contribution that really seems to be making a difference in the local community. My concern, as I said earlier, is that when these things, when the hype around private financing gets very large, the concern is that these not become they go from being a supplement or a complement to public funding to actually being a substitute. And there's a spreading ethos in many parts of the world that, really big tech companies and so on, they know much better than governments what to do. And so we really need to be careful about these things getting large, and especially if encouragement of these initiatives effectively means giving tax breaks to those companies. So that would be a very dangerous development. So last, just to say that I think, as I said at the beginning, we have certain principles for guiding health financing reforms. The word innovation comes up a lot when we talk about health financing. I actually think, and those who have been in our courses know, that I want to make health financing a lot more boring and make service delivery much more innovative and development, and locally responsive. We don't want innovation in financing to mean lots of fragmentation, but there's a lot of scope for innovating, if we say, or improving in terms of provider payment systems, the data systems, and so on. And again, dealing with the basics, so it's maybe not innovative, but at least dealing with the basics of what works and what's needed in public financial management systems. So I think let me stop there. I wanted to thank everybody for really good contributions. I learned a lot, and I hope these summarizing words were useful. Thanks.
Thank you so much, Joe. Thank you to all the panelists. This was a very interesting session, and I also enjoyed it. I really hope that our audience enjoyed it as well, and that they learned something that they could apply in their everyday work and research to advance DRM. We definitely at APTA Associates working a lot around the world through our flagship HSS project, Local Health Systems Sustainability and SHOPS Plus that we heard from, to advance this cause of DRM. And you can follow our work through social media or the website that is being shared on the slide. Again, this was very, very, very interesting. We know that everybody had a very busy schedule, but they stick with us and share their experience. So thanks to all our panelists from Kenya, Senegal, Tanzania. Thank you to Kelly for moderating, and thank you to Joe for those very, very pertinent closing remarks. We also want to thank the HSR organizers as they provided the forum to share this experience and this session. So to everybody, I want to wish a good rest of your day or beginning of it, depending on where you are, and see you back in the conference for other sessions. Thank you.
Thank you.
Thank you very much. Thank you very much.
Thank you.
Okay.
You see.
Did we stop from the audience slide? Hello to the host. Do you hear?